مع حضرتك. انت معايا كده؟ طيب كده قلب. انا لا. لو المكالمة مش باين. طيب هكلم حضرتك عن طريق البرنامج. اسأل الجماهير. ماشي. طيب تمام. بسم الله الرحمن الرحيم. برحب بحضراتكم في مراجعة الماسكولوسكيليتال سيستم، ونبتدي
Recording in progress.
زي ما احنا متعودين ان شاء الله. ديت اول حالة في بلين اكس راي للركبة، و انا بتكلم انجليزي في المراجعة ديت. طيب. And the first case you see an X-ray AB and lateral of the knee joint, and this is coronal T1, sagittal stair and axial stair. Then we can see your answers, and this is inchondroma. This is right. Inchondroma is a benign lesion, and when it occurs in the long bones, it does not cause a significant expansion, but it is well characterized by the presence of calcium inside, and also you may see some sclerotic margin. This is typical of an inchondroma. The next case is a child with hip pain and limping. Yes, and this is Bursa's disease, and it's not developmental hip dysplasia. You can say this, and Bursa's disease is also a right answer. And you see the significant flattening of the right capital femoral epiphysis and widening of the acetabulum. And also you may appreciate some sclerotic reaction in the affected epiphysis. The next case is an MRI of the knee, coronal, sagittal, axial stair images. Yes, then this is double BCL sign, which is diagnostic of bucket handle tear of the medial meniscus. In the coronal image, you can see that the meniscal fragment has been displaced to lie beneath the posterior cruciate ligament. And in the sagittal image, you see the BCL, and this is the meniscal fragment underneath. And in the axial image, which is one of the very informative images nowadays in the assessment of the knee, you can see that this is the medial meniscus. There is a fragment which is placed at each side, this fragment, and the big one which is displaced to lie beneath the posterior cruciate ligament. This is the displaced fragment, and the diagnosis is bucket handle tear of the medial meniscus. Then this is the CT scan, sagittal stair and coronal T1. As giant cell tumor, yes, and this is a good answer. And you see an osteolytic lesion with a rarefaction of the cortex, and the lesion is reaching the articular surface, which is diagnostic of giant cell tumor. And this is a case of female patient, 51 years old, MRI of the wrist, and this is axial, and this is a stair image. Yes, good answer. And this is rheumatoid arthritis, and you can easily see the erosive changes in the carpal bones, which appear low signal in the T1 and high signal in the T2, with characteristic erosion of the ulnar styloid process, as well as synovial thickening and effusion, which is seen between the carpal bones as well as in the distal radioulnar joint. The next case is an MRI of the knee, sagittal stair, axial stair. Yes, double delta sign, which means the bucket handle tear of the posterior horn of the lateral meniscus, or what is known as flipped meniscus. You do not see the posterior horn of the lateral meniscus. Both horns are located anteriorly, and if you look carefully to the to the axial image, and you can see that the posterior horn, which should be located here, has been displaced anteriorly, as you can see. Then this is also an MRI of the knee, and you can see this is the axial image, and this is the coronal one, and this is the sagittal image, and this is just an illustration of the pathology. Yes, what type of, yes, and then this is the radial tear of the meniscus, and if you look carefully in the axial image, and you can see the defect which corresponds to this area, and then this is the medial meniscus, and you can see the defect which is filled by fluid, and this is the radial tear of the posterior horn of the medial meniscus. MRI of the wrist joint, as well as the X-ray of the same patient who is 30 years old. Triangular fibrocartilage. The triangular fibrocartilage is not seen well in this image, but the pathology is in the lunate. It is not dislocated, but it show in the plain film some collapse and sclerotic reaction, as well as abnormal signal in the stir image, which is a vascular necrosis. Right answer, AVN of the lunate bone, which is also known as Kienbock disease. MRI of the wrist, axial T2 with fat set and axial T1 fat set with contrast enhancement. Um, Triangular fibrocartilage, this is not the area of the triangular fibrocartilage. Actually, and you can see here some fluid signal in the carpal tunnel, as well as in the distal radioulnar joint. Yes, and this is synovitis, and the most common type of synovitis in this area is due to rheumatoid, and here you can easily appreciate the degree of synovial thickening and enhancement, which is diagnostic of synovitis and effusion, commonly seen in cases of rheumatoid arthritis. Next case is a male child with foot pain. Yes, and this is collar disease, which means a vascular necrosis of the navicular bone. The navicular bone is collapsed and is relatively sclerotic, diagnostic of a vascular necrosis of navicular bone, which is known also as collar disease. And this is an MRI of the orbit, And you can see that there is a bony lesion which is affecting the lateral aspect of the orbit as well as the greater wing of the sphenoid. The lesion is expanding and it shows heterogeneous texture with some enhancement after injection of contrast. Fibrous dysplasia is the right answer, but the brown tumor of hyperbara needs some clinical data to support this diagnosis. But this is the fibrous dysplasia and a good diagnostic possibility. Of course, it's difficult to diagnose fibrous tumors by MRI because of the abnormal signal, but the plain film may be even more beneficial than the MRI. And this is the MRI of the elbow joint, and you can see a lesion along the anterior aspect of the elbow joint, and this is in the T1, and this is in the T2 fat set, and this is post contrast with fat suppression. No, there is no Birza in this particular area. And this is one of the most common soft tissue tumors seen everywhere in the body. No, this is not a ganglion cyst and not myositis. But the clue here is the very bright signal of the lesion in the T2. And this is always indicate that you are dealing with the hemangioma. And yes, and this is of course a hemangioma. And in the T2 weighted image also you can see some black lines within the tumor which represent fibrous septa. And you may also see some dots of signal void which may represent vessels or calcified fibrillary. He also suspected that hemangioma will not enhance significantly in the musculoskeletal areas, but hemangioma can enhance evidently in the liver, for example. And whenever you see that there is a lesion with significant brightness in the T2 weighted image and the internal fine low signal lines, you may suspect, of course, the hemangioma. This is an X-ray of the ankle joint, the frontal view and the lateral view. Yes, and this is osteoarthritis, severe osteoarthritis of the ankle joint with all the findings of osteoarthritis, narrowing of the joint space, subarticular bone sclerosis, osteophytic clipping of the articular surfaces, and you may appreciate some pseudocystic changes as well. This is a severe ankle osteoarthritis. And here some of the x-rays of the knee and wrist joint with some magnification at the area where the lesion is present. Pseudo-gout, a good answer. Yes, and this is known as pseudo-gout or calcium pyrophosphate dihydrate deposition disease, or CPPD, and where you got calcifications in the articular cartilage and calcification in the menisci as well as the triangular fibrocartilage. This is an ankle MRI, T1 and T2 fat set. Tenosynovitis of which tendon where you got tenosynovitis? No, this is not tibialis anterior. This is the tibialis posterior. And actually, if you look carefully, the tibialis posterior is large. And this indicates that you are dealing with type 1 injury of the tibialis posterior when compared to the flexor digitorum and the flexor hallucis longus tendons. Also, the tendon is surrounded by a fluid signal indicating tenosynovitis. Then the right answer is type 1 injury of the tibialis posterior tendon with tenosynovitis. This is MRI of the foot. Fibromatosis, you mean plantar fibromatosis? There is no masses here. Plantar fasciitis, this is the right answer. And you got some abnormal signal surrounding the plantar fascia with edematous changes in the fat in the sole of the foot. And here you can also see in the coronal image, and this is diagnostic of plantar fasciitis. Male, 18 years old, and this is axial CT image of the knee after injection of contrast material inside the joint. Okay, and you got the answer. This is osteochondritis dissecans of the patella. This is right. You know that osteochondritis dissecans is a term applied for avascular necrosis in the femoral condyle. But this term can be also used instead of avascular necrosis, which means the same. And this can also affect the patella, as you can see here. Next case, and you got X-ray of the knee with a big calcified mass, and you see also in the CT scan. Yes, chondrosarcoma is a good possibility. Osteosarcoma is also a good possibility, and the right answer was high-grade osteosarcoma. Of course, the extensive calcification and the areas of bone destruction and so on in the metaphysis of the long bone may suspect the possibility of osteosarcoma. But if your answer is chondrosarcoma, there is it can be considered as a right answer. This is MRI of the shoulder, is coronal T2 weighted image. A slab injury, yes. Which type? Type 3, and then this is type 3 actually. And you got type 2 is separation of the labrium from the glenoid part. But type 3 is a line passing through the labrum, separating it into two parts. And this is a slab type 3 injury with some effusion, of course, in the joint. And this is MRI of the ankle and T2 and stair images. Densoma, no. In densoma, the tendon is markedly enlarged, but this tendon is slightly swollen. Achilles tendinopathy and retrocalcaneum bursitis and subcutaneous inflammation, all these form the syndrome known as Haglund syndrome. And this is Haglund syndrome with tendonitis of the Achilles tendon, retrocalcanean bursitis, and subcutaneous inflammation or retroachilles inflammation. And the three components represented the Haglund syndrome. Male, 35 years old, with X-ray of the cervical spine. No, this is not ochronosis, and no, this is not ossification of the posterior longitudinal ligament, and is not dish. Dish means extensive ossification of the ligaments, and this is a simple ankylosing spondylitis of the cervical spine. And you see some calcification of the anterior longitudinal ligament as well as the posterior longitudinal ligament, obliteration of most of the neurocentral joints as well as the facet joints, and these are the classic findings in cases of ankylosing spondylitis. Male, 13 years old, with a lesion in the fibula. This is the destructive lesion in the fibula by CT and high signal in the T2 fat set and the low signal in the T1. This is Ewing sarcoma, right? The answer is right. Destructive lesion representing in Ewing sarcoma. This is a child also. You see the capital femoral epiphysis is not yet united with the metaphysis. And in the T1 stair and post contrast, you got some low signal surrounding the hip joint and high signal in the T2 with some enhancement. Very good. The answer is good, and this is septic arthritis, or if you just say that this is synovitis, it's okay. But whenever you look carefully, and you can see there is also inflammation of the bone with bone marrow edema and then synovial thickening and enhancement, and this is septic arthritis of the hip joint. Very good. This is a male patient, 32 years old. MRI of the wrist joint, coronal and sagittal T2 weighted images. Okay. No, this is not pigmented venonodular, but synovial chondromatosis is a good possibility for this appearance, although it is presented in the literature as rice bodies of rheumatoid arthritis. But actually, whenever I see this case, I said that this is synovial osteochondromatosis because the lesions are very big to be described as rice bodies. But the answer, whenever you say that this is synovial chondromatosis, and you are right. Skull, X-ray, EB and lateral. Yeah, paper and salt sign is a good sign, is a good answer, but what does this sign means? Multiple myeloma is not right. What do you mean by salt and pepper? Yes, and this is hyperparathyroidism, a good answer. And you got rarefaction of the calvarial bones with some erosive changes or demineralization of the outer table and the inner table, which are some of the classic findings of hyperparathyroidism. Okay, this patient had a history of multiple gunshot wounds resulting in spinal cord injury and paraplegia. He is 25 years old. Yes, myositis ossificans is a right answer. This is an extensive type bilateral myositis ossificans around the hip joints. Good answer. This female, 24 years old, with long-term bilateral knee pain, worsened by activity, suspected to have chondromalacia patella. Bone islands, and whenever these bone osteobiclosis, yes, this is the right answer. Osteobiclosis, multiple bone islands, extensively distributed everywhere in the body, particularly in the pelvis and in the hands. And this disease is rare in the spine, and as the literature say, the spine, the ribs, and the skull are not involved. But I have seen many cases where the spine is affected as well. You got multiple small sclerotic lesions in the range of 5 millimeter in diameter, and they do not show significant uptake in bone scan, and this can easily differentiate these findings from the metastatic bulbs. Also, whenever you see lesions peripherally located in the fingers and in the phalanges, you know that metastases are very rare beyond the elbow and beyond the knee. Next, and this is a case of plain X-ray of the knee, T1, T2, sagittal and coron. Yes, this is a classic appearance of Brod's abscess, which is surrounded by a halo of bone marrow edema, black in the T1 and bright in the T2 weighted images. This is a Brod's abscess. Next case, male, 75 years old, and this is the tibia. Adamantinoma, yes. Um, Two lesions that can produce this appearance in the tibia. One of them is adamantinoma, and the second one, not the fibrous dysplasia, of course. But what do you think? Yeah, yes, the disease which cause enlargement of the bone, significant enlargement of the bone, and this is Paget disease of the tibia. Of course, the adamantinoma do not cause enlargement of the bone, but it cause some bending or bowing of the tibial shaft. But the only disease, in my opinion, which can cause significant enlargement of the bone compared to the normal size is the Paget disease. Then this is MRI of the knee, and this circle shows the pathology in the meniscus, and also you got other lesion here and one other lesion there. Vertical tear of what? Vertical tear. Well, vertical tear of the lateral meniscus and ACL. What do you mean by ACL? Tear. And yes, and this is ACL tear and lateral meniscus vertical tear with bone marrow edema, and you got ACL and lateral meniscal tears. You see that the ACL is lying down against the tibial plateau with some abnormal signal within its fibers. Also, you see bone marrow edema, kissing contusions, or pivot shift lesions. And this is a child with an osteolytic lesion here, and this is the CT scan of the same case. No, Ewing is not an expanding lesion like this. Giant cell tumor will reach the articular surface, and this is not the age of giant cell tumor. Giant cell tumor will arise after epiphyseal closure, after the age of 20 years. Aneurysmal bone cyst is the right answer. And this is aneurysmal bone cyst, and if you look carefully in the CT images, you can see the characteristic fluid levels within the lesion, which is expanding as you can see here. And this is aneurysmal bone cyst. This is a male child. It's not a child, let's say adolescent, 15 years old with back pain worsening by posture. Okay, Sherman disease, right answer. And Sherman disease is also known as adolescent kyphosis. You got some kyphos deformity in the adolescent age, and of course you have many of the criteria to support the diagnosis of the disease. These are known as Sorensen criteria for diagnosis of Sherman disease. Number one, thoracic kyphosis with an angle more than 40 degrees. I will show how to measure this angle. Thoracolumbar kyphosis more than 30 degrees. At least three vertebra, adjacent vertebrae, demonstrating wedging more than 5 degrees. Other signs, vertebral end plate irregularity, and you got multiple Schmorer's nodes, as you can see here. Intervertebral disc space narrowing, of course, you can appreciate, and apophyseal separation. The condition is associated with Schmorer nodes, limbus vertebra, which means that the accessory ossification center is not united with the vertebral body. Sometimes scoliosis, sometimes spondylolisthesis. And this is the way how to measure the degree of kyphosis. You select the upper vertebra where the kyphosis is going to be corrected, and also the lower vertebra. You draw a line parallel to the end plate of this vertebral body and another line here, and you measure the angle between these two lines, and this is known as the angle of kyphosis. Then if the curve is slightly wide and these two lines will not meet, then you, as you do in the scoliosis, you insert a perpendicular line to this one and another perpendicular line to this, and you measure the angle in between. Next case is an MRI of the shoulder, and this is sagittal T1, and this is also sagittal T1. Yes, a very good answer actually. And the frozen shoulder, and I wanted you to appreciate this sign. Previously, I used to say that the frozen shoulder is diagnosed by thickening and tightening of the inferior glenohumeral ligament, and also you got thickening and tightening of the capsule at the rotator interval. And you know that the rotator interval is the space between the supraspinatus and the subscapularis. And this space runs the coracohumeral ligament, this ligament. And there is some fat around the ligament. Then the criteria of frozen shoulder or adhesive capsulitis is you got thickening of the coracohumeral ligament and the obliteration of the fat surrounding this ligament in the rotator interval. These are some of the supportive signs for adhesive capsulitis. This is the normal appearance. You see, this is the rotator interval between the supraspinatus and the subscapularis. And this is the coracohumeral ligament, and this is the fat in the rotator interval. You see that the fat is preserved, and the ligament, this is the normal thickness of the coracohumeral ligament, but here the ligament is significantly thickened with obliteration of the surrounding fat. Then adhesive capsulitis means that there is capsular and synovial inflammation causing restricted motion of the joint. This may be primary of idiopathic type or secondary to trauma or repetitive trauma or surgery or rheumatologic conditions affecting the joint. The rotator interval capsule is composed of the coracohumeral ligament and the superior glenohumeral ligament, but the most evident one in imaging is the coracohumeral ligament. Then this is the normal appearance, and you got the coracohumeral ligament, the rotator interval, and the fat. But here you see that the coracohumeral ligament is markedly thickened and the fat is obliterated. If you go to the coronal image and you see that the inferior glenohumeral ligament is markedly thickened and shortened. These are the signs of the frozen shoulder. Next case is an X-ray of the pelvis, CT and MRI, showing a big mass with matrix calcification. Yes, and the right answer, chondrosarcoma, big mass with matrix calcification, destructive changes in the adjacent iliac bone, and you got brightness in the T2 weighted image because the chondroid matrix is very bright, and the T2 weighted images may be similar to the fluid or to the CSF. This is chondrosarcoma. And this is MRI of the knee, sagittal T1 and sagittal stair or T2 fat sat and axial T2. Yes, and this is lipoma arborescens, and you got a branching frond-like projections made of fat within the synovial compartment of the knee joint, and you got some effusion which has enabled you to see the extension of the fat. And this is a male, 19 years old, with football player, and had acute injury to the shoulder. Posterior pancreas, good answer, but yes, and this is reversed pancreas, but if you look carefully here and you see that the posterior labrum, yes, this is the right answer, which is bullapsa, because the posterior labrum has been separated from the glenoid, but the periosteum connecting it to the scapula is still intact, and the labrum is displaced a little bit medially, and this is typical findings for the bullapsa, which is the opposite of a lapsa lesion, which affects the anterior labrum. هذا وبالله التوفيق.